Okay, I hope all of you are looking the slide. The slide is visible to you all.
Yes, sir.
Okay, so today we will be talking
Yeah, sir.
about pharmacotherapy of diabetes mellitus. Okay, in the background it shows the symptoms of diabetes mellitus, which you are familiar. Okay, and we have already discussed. So now today we will be talking till yesterday's class we talked about the drugs which are used in diabetes mellitus. We also talked what is diabetes mellitus and other, isn't it? So today using all those pharmacological knowledge we will be applying to the disease that is in diabetes mellitus, how we are going to treat or how we will approach. Okay, and remember this diabetes mellitus, it is a very big topic. It is very common and it is bread and butter for most of the physicians. Okay, so that is why there are a lot of research going on, lot of information there, isn't it? So after finishing today's class, it is like opening window to diabetes mellitus. It is not, we are not closing the chapter. We are rather, we are opening. Okay. So it will be open for the clinical aspect. There are many more things which is uncovered which you have to learn, and you will be learning in clinical and after that in MD. Okay, and even after that DM, when you want to do DM in endocrinology, again diabetes mellitus is something very important. Okay, so anyway we will try to make it little bit clear. Even the window, the glass of a window should be clear. Okay, so that you can visualize what it. Okay, so that is our aim of today's class. And in diabetes mellitus, talking about the diabetes mellitus, what we want to achieve with our therapy, the therapeutic goal, what a doctor want to achieve, okay, is generally two things. Number one is to relieve the symptoms of hypoglycemia. Okay, there is hypoglycemia, you want to control, you want to relieve the symptoms. Okay, and when you control this hyperglycemia, of course it will lead to prevention of complications. But this is one thing. The other is that you will try to, because this diabetes mellitus, it is a metabolic disorder, so you will try to achieve to make this metabolism near normal. Okay, the metabolism which has been disturbed due to diabetes mellitus, you will try to bring back to the normal. So controlling the glucose level. Why do you want to control the blood glucose level? As we have discussed in very first class, to prevent the acute and chronic complications, isn't it? So that is why we want to relieve the symptoms or control the hyperglycemia. Not only the hyperglycemia, we want to make the metabolism near to the normal. Okay, so this is the goal. And how do we achieve this goal? Okay, approach to manage the diabetes mellitus or to achieve that goals which we have is number one is non-pharmacological measures. And from the very first class I have been emphasizing that this even though non-pharmacological measure doesn't include the medicine, but it is some of the very important and very crucial part, okay, very essential part of management of diabetes mellitus. So these non-pharmacological measures includes the diet and exercise. Okay, so in diabetes mellitus we try to manage this with at least looking into the three aspects. One is the diet, next one is exercise, and the drug. Okay, so these three. So to achieve that goal, we do non-pharmacological measures, and of course, we will be using medicines. Okay, so we will talk a little bit about diet and the exercise, the lifestyle modifications. And I have already said it is a very big chapter. Even a dietitian, for dietitian, also this diabetes mellitus is important. So they have a lot of long list of dietitian have long list of things which are to be taken, which are to be avoided by the patient. But we will be talking about very essential part of non-pharmacological measures, and of course the medicine which we have already discussed. Now, how to choose that medicine? What is the approach? Okay, so we will be talking about that. So to manage the diabetes mellitus, there are two aspects. One is non-pharmacological measure and the other one is pharmacological measures. Okay. Uh, got it?
Yes, sir.
Okay. So talking about the diet, okay. Diet, generally we try to achieve good glycemic control, and generally in diet we say that carbohydrate should be reduced, and the carbohydrate with low glycemic index, okay, a complex type of a carbohydrate, unprocessed carbohydrate which has low glycemic index should be preferred, okay, like chapati and other, okay, we used to say. And the carbohydrate with high glycemic index should be avoided, okay, or minimized, okay. Apart from that, salt restriction is also important, okay. um, and avoiding atherogenic diets, okay, like we have said that the lipid level will also be disturbed, isn't it, deranged. So that is why that may lead to atherosclerosis. So that is why we try to avoid those diet which aggravate high protein intake in nephropathy. If the patient is nephropathy, if the kidney is damaged, then we have to uh, decrease if no working, okay, the protein can be continued. So that is and for other problems is not only that to weight also increase the complications, okay. So that is, and apart from that, even the exercise to reduce the weight, exercise is important. Not only that, the exercise also spares the insulin, okay. And this the exercise increases the peripheral uptake of glucose, okay, by sparing the insulin. So that is why exercise is very, very important in the diabetic patient. Okay, so we ask for exercise also. So diet and exercise are important. Okay, and talking about the diet, how it should be. Okay, just a preliminary thing. Okay, we are just talking about the essential part. So this is a plate model for meal planning, and this is taken from Davidson Medicine in 20th edition. It is there, okay, 20th edition. Okay, in latest it is not there. So anyway, this plate model could be easily we can explain to the patient. Okay, what the diabetic patient should do. Okay, so it is divided. The plate, the meal plate is divided into three parts, and this smallest part, that is 1/5 of the plate. Okay, 1/5 portion of the plate should be fish, meat, eggs, cheese, etc. Okay, and the left, okay, um, 4 portion out of 5, okay. 1/5 is this small portion. The other is divided into two equal halves, and this one half should be, okay, loaded with vegetable and fruits, and then the other is rice, pasta, bread, potatoes, etc. Okay, so this is how it should be divided. So this is a very essential thing that you have to know. Apart from that, there are frequency of meals, isn't it? Each meal contain what it should contain. There are a lot of things that has to be known, okay, by the consultant. So that will be discussed in clinical and other things. But for this level, at least you should be aware that in non-pharmacological measures, the carbohydrate should be reduced, and the carbohydrate with low glycemic index should be preferred. Okay, and then the patient should eat or the diabetic person should eat more vegetable food. Okay, and of course go for exercise, reducing salt, okay, etc. So that is the important thing. Now talking about the management, how will you manage, okay, in type 1 diabetes mellitus patient. Okay, in type 1 diabetes mellitus, insulin is must. From the very first class, I have been telling you that for type 1 diabetes mellitus, insulin is given because the body, the pancreas, beta cell of pancreas is unable to uh, produce the insulin. So that is why insulin is must in type 1 diabetes mellitus. But remember, if type 1 diabetes mellitus, the patient is non-obese, you have to use weight maintenance diet. Okay, while if the person is obese, then low energy diet, so that the weight could be lost. Okay, so that is. And of course, for type 1 diabetes mellitus management, the first line treatment is insulin and diet. Okay, and this insulin could be given by three method. Okay, that is insulin regimen. How insulin could be given by three. One is what we say multiple injection or basal bolus. Okay, or bolus method. And second one is what we say split mixed insulin. This is twice daily insulin in combination. Okay, that is generally we say split mixed regimen. This is split mix regimen, and next one is basal bolus. Okay, and in some cases in diabetic ketoacidosis or some other complications, sometimes we use insulin as a continuous subcutaneous injection infusion. So this is, but these two are most commonly uh, preferred one. One is multiple injection basal bolus, and this what we say is split, split, split I E T mixed, okay, regimen. This is REG. So there are two. One is bolus, okay. Next one is split mix regimen. So we will talk this in little bit detail, okay. So the insulin, what we do is like suppose this is a graph, okay. Even this graph you can find in KD Tripathi also. One is here insulin concentration, okay, by time, okay. And we have said that naturally the insulin is released. Okay, if I plot a graph, then what happens when we take a glucose, okay, at this point, say suppose, okay, it is very difficult to write here. Okay, anyway, if I give glucose, then you know that there are two phases. One is a rapid phase, okay, and then there will be delayed phase of insulin release. So two phases there, isn't it? Naturally, insulin is released in this way. Yes or no? Okay, this is first phase, and this one is second or delayed phase. Okay, so there is a level of insulin in our body. Okay, and when we take some meals or other, the insulin will be released okay, fast and in little bit high concentration. So that is first phase. So this is what happens. Now insulin generally, so this is the natural in our body. Naturally this happens. Okay, now what is the bolus regimen? Bolus regimen is here at, okay, mm, suppose this is 10 a.m. in the morning. We give some, so this is a 10 p.m. Okay, so at 10 p.m. generally we give insulin glargine. Here we give insulin glargine, Glargine, glargine. This is a longest acting insulin. It act for 24 hours. There is a peak less insulin. So what happens? The insulin concentration, when we give at 10 p.m., the insulin concentration so slowly rises and it remains for 24 hours. So that is why it is, yeah, still the level is in this, and will fall at around 10 p.m., where again second dose is given. Okay, so this is basal. This is, okay, basal. Okay, basal dose is produced by glargine. And when we take a meal, okay, a major meal, like generally 3 or 4 times a day we take a meal, isn't it? Yes. So while before taking the major meal, we take some very fast, rapidly acting and a short acting insulin, like insulin lispro, LISPRO. Suppose at 8, this is 8 a.m. in the morning. So if I take lispro, then what will happen? It will act for short period of time. Okay, it will act rapidly and will act for short period of time. Okay, so this is what we say bolus. There is a basal level and there is a bolus level. So this is lispro. When I take a major meal to take the glucose or say to check the blood glucose, the insulin we have given, and that is lispro. And maybe at around 12 o'clock again next meal is taken, isn't it? So again we will inject the second dose. Maybe at 3 or 3 we will sorry, so here the timing, okay, just you what, just a minute. Okay, 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 suppose this is 10 p.m. Okay, and then we inject glargine. So here maybe here we will give a next dose, maybe at this time we will give. Okay, so this is bolus, lispro or short rapid acting insulin, and glargine is given. Okay, this in this way also we can give the insulin. If you see the insulin, the pattern will be more or less similar to natural one, isn't it? A peak and then the second phase, isn't it? So this is known as basal bolus regimen. Basal is obtained with glargine, a long acting, or glargine or any long acting preparation. Generally, we prefer glargine as a long acting preparation, and a rapidly acting in insulin analogs are given, okay, before the major meal, and this is what we say basal bolus formulation. And while the other one is, okay, the other is suppose again insulin and time, okay, maybe 10 a.m. okay, and 10 p.m. Okay, in this case what we use is we use a preparation, okay, which contains like regular insulin, REG, regular insulin plus NPH, you know, isn't it? What is NPH? Anyone?
Neutral protamine hesitant.
Okay, neutral
Hegedol.
protamine insulin, isn't it? It is what type of insulin is this?
Intermediate act.
Yes, it is intermediate acting intermediate, and this is what fast and short acting, isn't it? Fast and short acting insulin. This is intermediate, it is slow acting, slow and intermediate acting, slow and intermediate acting. So we mix these two insulin and give. So what will happen when I give this mixture? Okay, so that is why it is said split mixed regimen. It is mixture, mixed regimen, mixed regimen. It is a split mix two mixer. So what will happen if I inject this mixture? The regular insulin will be released immediately, okay, it will act fast and for short period of time, and at the same time this NPH will slowly start acting, okay, slowly, and then will take over, okay, maybe like okay, maybe something like this, in this way, okay. And so morning during breakfast we will take this, and evening at dinner time again the next mixture is taken, so it the short acting will act immediately, and then the intermediate acting which we have taken may act slowly but for long period of time. So this is known as split mixed regimen. This is SPLIT, split mixed regimen. Okay, so insulin, it could be given in this way. One is basal bolus, next one is what? Split mixed regimen. So most common till now, the most common is split mixed regimen, but this basal bolus is also gaining popularity slowly. Okay, so this is the two way of giving the insulin, and here it is given in such a way that so that it becomes like almost normal, okay. And this split mixed regimen, they are available in a vial, okay, that you might have heard 30-70 insulin. Anyone who have heard about 30-70 insulin? Any one of your say family member is using insulin? 30-70, or we have 50-50 insulin, okay. This is split mix. This means 30% is regular insulin and NPH insulin is 70%. While in 50-50 means regular insulin is 50% and NPH is 50%. Okay, so if you want more this first phase to be more, then you will be preferring 50-50. If you want less, maybe 30-70 you will be preferring. So this, all those which is available, no, this type of formulation is like split mixed formulation, and it is split mixed regimen. So in this way also we can give insulin or in basal bolus form. Okay, got it? Any doubt? If you have any doubt, please ask. I am not listening any voices. What should I understand? You are clear about this, or yes?
Yeah.
Yes, sir.
Yes, sir.
Okay, so this is what, okay, here. Now this split mixed, now here twice daily insulin in combination is given. Soluble, that means regular insulin, or fast acting analog, we give regular insulin or fast acting analog along with isofen or longer acting analog. So we will be doing this. And in this multi injection or basal bolus regimen, the short acting insulin is given before meal. Long acting insulin once or twice daily we give separately. Generally once daily we prefer, and we prefer the glargine. Okay, so we give once daily the longer acting, which will take care of for 24 hours, and then just short acting insulin before the meal. In this way also we can give, or we can mix the two insulin, the fast acting and an intermediate acting in a same vial, or you can say in same syringe, and giving twice a day. Okay, got it? So this is the two way of giving insulin, so which is done in type 1 diabetes mellitus. Okay, so this is the management. Okay, if the person is the diabetic patient is non-obese, we go with weight maintenance diet, and if the person is obese, then we give low energy diet. Okay, along with insulin. So insulin is must for type 1 diabetes mellitus. Okay, what about the management of type 2 diabetes mellitus? Now, this is a chart, okay, taken from Davidson Medicine 22nd edition. It is a recent guideline. Okay, if someone asks you, okay, like the question, and you have answered from this, and if they ask from where you have read, don't mention that it was discussed in Sudesh sir class. Tell it is from Davidson 22nd edition. If you have, just go and check that also. Okay. So in management of type 2 diabetes, if a person with type 2 diabetes mellitus come to you, then what you have to do is you have to set the glycemic target, what you want to achieve. Okay. And this is glycosylated hemoglobin 1C. Okay, generally it should be less than 7%. Okay, in diabetic patient, generally we try to make it less than 7 or 6.5%. Okay, so whatever you agree, you make a goal. Okay, this is your goal to be achieved. Set a target. Then to achieve this, you can ask the patient to for modifying the diet and exercise. Okay, maintain lifestyle adjustment. So non-pharmacological measure you will start. If that non-pharmacological measure is sufficient, it is well and good. Just monitor the patient. If it is not sufficient, then you start with metformin. First line option is metformin. Okay, we have in yesterday's class we have discussed why metformin is a first line drug. So remember, this is a guideline, and it says that metformin should be started in type 2 diabetes mellitus. Okay, if intolerant of metformin, or if weight loss osmotic symptoms are there, okay, there is weight loss osmotic symptoms, okay, then you will go with sulfonylurea. It is preferred metformin. Metformin, you can, if you cannot give it, then go with sulfonylurea. Okay, and generally This is sufficient, and sometime metformin alone may not achieve your this target. Okay, generally achieving the target may be difficult. So if you are using metformin, then combine sulfonylurea. Okay, if metformin alone is sufficient, it has achieved the goal, well and good, continue. Okay, if it is not, then what will you do is you will add sulfonylurea with metformin. Okay, or if sulfonylurea could not be given, then go with thiazolidinediene. Or if hypoglycemia is a concern, okay, you cannot okay, take the risk of hypoglycemia in the patient, or if no cardiac failure, then you okay, thiazolidinediene should be preferred. If you don't want the patient to land up with hypoglycemia, then give thiazolidinediene, but ensure that there is no cardiac failure. Okay, and if hypoglycemia is concerned, or if weight gain is also concerned, you do not you want the patient to lose the weight or do not want to increase the weight, then you go with DPP4 inhibitor. So combine metformin with either sulfonylurea or thiazolidinediene or DPP4. Okay, so this is the second line, go with this. So whatever as per your need, you may go with metformin plus DPP4 combination, or metformin plus thiazolidinediene, or metformin plus sulfonylurea. Okay, and these two, okay, is not sufficient, then you will go with the third option. Okay, generally what happens in diabetes mellitus, in initial stage the diet and metformin is sufficient. It will take care for few years. After okay, continuing this treatment for a few years, that may not be able to achieve this target. At that time you have to add next drug, and if that is also not controlling, then you can go with the third option. Okay, third option, you go with add. Okay, if you have added metformin plus sulfonylurea, now in third option add thiazolidinediene or DPP4. Okay, or no, you have already added this, then you can go with injectables also. Okay, injectable like insulin. So that is why generally what happened, type 2 diabetes mellitus is managed with diet, exercise and metformin. If it is not sufficient, we will add the other oral anti-diabetic drug. And third, so we will try on going and trying with the combinations. At last, okay, on the chronic diabetic patient, sometime what happened, the oral hypoglycemic agent may not be sufficient. Okay, with all those combination, at that time lastly you will start insulin. Okay, so type 2 diabetes mellitus on chronic use may have to may want insulin for the management. So this is the guideline which we follow for type 2 diabetes mellitus. Okay, so this is the therapy. If you have any doubt, then you can ask. Okay, roll number 95. Who is roll number 95?
Yes, sir.
Okay, now can you tell me how will you manage type 1 diabetes mellitus?
So for type 1, insulin is must, and there are different regimen to treat insulin. Firstly, we should, if there is a obese person and non-obese person, to for obese person diet management, and for non-obese person we should consider weight. And two type of regimen for type 1 diabetes mellitus. And first one is basal bolus. In this, we give insulin, short acting insulin before meal, and one long acting insulin like glargine.
Yeah.
And second regimen, we have multiple multiple we give twice short acting and intermediate acting insulin, which can be given combinedly.
Okay, so here in type 1 diabetes mellitus, the diet is important, whether it is obese or non-obese. But what we do is we consider weight maintenance diet in non-obese patient and low energy diet in obese patient. Okay, so diet maintenance of diet is important in both obese or non-obese in type 1 diabetes mellitus. Got it? So insulin is must, and this is, and this insulin we can give by two way, isn't it? You have already said correctly. One is multiple injection. We will go on giving multiple, like we will be giving one acting insulin, and then whenever, for if someone is taking three times 3 meals per day, okay, measure meal, then 3 times the patient will be injecting. If the patient is taking 4 times, then 4 times injecting the short acting. So four times short acting injection and one a long acting injection. So altogether 5 times there will be injection. So that is why it is said multiple injection or basal bolus. While in this split mixed regimen, we have a insulin with mixture of regular insulin, a short acting, fast acting insulin plus an intermediate acting. Okay, so that is split mixed insulin, and that will be injected twice a day. Okay, so that is the other way you can give insulin. Okay, got it? Roll number 90. Roll number 90. Absent?
Yes, sir.
You are roll number 90 or 90
90.
is absent? You are 90.
Yes.
Okay. Can you tell me how you will manage type 2 diabetes mellitus?
In type 2 diabetic mellitus, first, we need to set the glycemic target. It should be less than 7%. The glycosylated glucose should be less than 7%, or the patient is
Glycosylated hemoglobin. Okay, yeah. Yes.
glycosylated hemoglobin should be less than 7%, and the patient is suggested for the maintenance of the diet and exercise. If these two condition lead in the if these two conditions and make the glucose in the normal level, then we shouldn't go, or then we shouldn't prefer the medicine. If it doesn't control, then we have the three options. And in first line option we have the metformin. If the metformin is intolerance, or there is a problem of weight loss or osmotic symptoms, then we prefer the sulfonylurea. Then if the sulfonylurea is also contraindicate, or there is the problem of hypoglycemia and the patient do not have any cardiac failure, then we can give the thiazolidinedione. Similarly, we can also prefer DPP-4 inhibitor, or if the patient is having the hypoglycemia and the weight gain problems. And similarly, in third line option, we can also give the oral and injectable drugs. In oral drugs, we can give the like in second line option, we can prefer the same drugs in the oral type, but in injectable, as the last option, we use the insulin and the GLP-1 agonist.
Yes, very good. So here, a type 2 diabetes mellitus, what we do is we first try to manage it with the diet and exercise. If it is not, then the first drug to be preferred is metformin, number one. Okay, and the second drug to be preferred is sulfonylurea. Okay, and then of course other you can go on adding. So first line drug is metformin, and if metformin is could not be given, okay, because of contraindications or some other reason, then you will switch over to sulfonylurea. Okay, no metformin could be given, then it is continued until it is working. If it is say could not work or could not achieve the goal, then you can add with sulfonylurea, then other group. And if the oral anti-diabetic drug fail, then we add insulin. Okay, so that is the management. So this is all about the management of diabetes mellitus. Now let us talk about the complications, especially the complication. We won't talk more about the other complication, the acute complication, that is diabetic ketoacidosis. We will be talking about this. Okay, so diabetic ketoacidosis, as name suggests, there are three things. One is diabetes, next one is keto, and acidosis. Three. So cardinal feature is diabetic means hyperglycemia. There is ketone bodies and acidosis. Okay, so these three we have to target while treating this. So it is a medical emergency, and it is common in type 1 diabetes mellitus. Okay, in type 1 diabetes mellitus who are taking insulin, in those patients it is more common, and there is precipitating factor for diabetic ketoacidosis. This precipitation could be due to stress, infection. Okay, stress, infection, what does they do is they increase the corticosteroid level in our body, and corticosteroid act opposite to that of insulin, isn't it? So that is why the glucose level increases very high. Okay, because of that stress, infection, the corticosteroid level. Okay, or sometimes stoppage or reduced dose of insulin can also cause diabetic ketoacidosis, or sometimes you may not be able to find the cause. Okay, so no cause. So it is a medical emergency. The treatment has to be started immediately. Okay, and cardinal biochemical features. Cardinal features, as I have already said, diabetic, that means hyperglycemia is there. Hyperketonemia, the ketone level in the blood will increase. So that is why it is said diabetic keto, and there is metabolic acidosis also. So that is why diabetic ketoacidosis. So while management, what you will do, you have to think of these three things. You have to try to control what? Glucose level. How can you control the glucose level? Roll number 89. Roll number 89. Absent? 88?
Yes, sir.
Okay. How can you control hyperglycemia?
So by giving insulin.
Yes, very good. You will be giving insulin. Okay. Now we will be talking about the other things also we have to consider. Okay. But remember, there are three cardinal features, or there are three part which has to be managed, or you have to consider while therapy. One is hyperglycemia, ketonemia, and metabolic acidosis. Okay. So now what happens here is hyperglycemia, blood glucose level may be very high, like generally it should be less than 140. Okay, but the patient with diabetic ketoacidosis may come the glucose level may be around sometime 900 also, 500, very high hyperglycemia. And remember, this diabetic ketoacidosis, it is not necessary that always you will find the patient in a coma state. Okay, sometimes the patient with diabetic ketoacidosis will come to you in your OPD also. Okay, even though with the very high blood glucose level. So this very high blood glucose level, what does it do is it causes osmotic diuresis. A lot of glucose is lost from the urine, and when sugar is lost, at that time there will be osmotic pressure will increase, and it will lead to diuresis, and it leads to dehydration. So that is why in management of diabetic ketoacidosis, you have to think of this dehydration and electrolyte loss also. Okay, and this hyperglycemia also causes lipolysis, which lead to more formation of fatty acid, and that leads to acidic ketones. Okay, so that is the reason for that. So when we control the blood glucose level, then of course slowly these diuresis and then lipolysis, or say you can say the problem of ketonemia could be checked. Okay, so this is that. Okay, now what are the symptoms of diabetic ketoacidosis? Is there will be polyuria, thirst, weakness, leg cramp, because leg cramp due to electrolyte imbalances, abdominal pain, weight loss, nausea, vomiting, blurred vision, etc. Okay, symptoms of diabetic ketoacidosis. And the sign of diabetic ketoacidosis is dehydration, cold extremities, tachycardia, air hunger, smell of acetone, the fruit-like smell you will find, okay, in the brain, and confusion, drowsiness. The patient may come with coma, but it is not necessary always the diabetic ketoacidosis will be in coma, okay, and hypotension and hyperthermia. Okay, these are the signs and symptoms of diabetic ketoacidosis. Now, how will you manage? Now, first and foremost thing for the management of diabetic ketoacidosis is you have to control the blood glucose level. So that is why you have to use insulin, and this insulin is given intravenously. And for intravenous, we prefer regular insulin, like other intermediate insulin. Okay, the protamine insulin, or you can say zinc insulin, they are not preferred. And remember, those insulin, when we see it, looks like suspension or rice water. Okay, while regular insulin is very clear solution. Okay, so that is how by just visualizing the insulin, also you can identify which insulin to be given. So regular insulin, which is a crystalline insulin, what we say. So or soluble insulin, it is given. Okay, so it is given IV, 0.1 to 2 unit per kg, which is followed by 0.1 unit per kg per hour infusion. Okay, and if the dose is titrated, this insulin dose is titrated. If that is sufficient, well and good. If it is not sufficient, then the rate of this infusion is doubled if there is no response. Okay, and remember, we don't make the blood glucose level to directly to the normal. Okay, what happens is we will give insulin, maintain the blood glucose level at around 200 to 250. Generally, after 300 mg per dl, okay, 300 mg per dl, we try to maintain that. Okay, and this blood glucose is level is maintained till the patient becomes conscious. Okay, and what is the reason of maintaining this is, if you maintain this, then slowly the ketone body will be eliminated from the body. Okay, so I have already said that you have to think of the three things, isn't it? At least one is hyperglycemia. So for hyperglycemia, you are giving regular insulin, isn't it? And but the blood glucose levels will be maintained at around 300 mg per dl. Why? If you maintain this, then slow the ketone will be eliminated. If you bring back to the normal, then elimination will be hampered. So that is why it has to be maintained at this level. Okay, got it? '87.
Yes, sir.
Yes. Why the blood glucose levels should be maintained at around 250 or 300? Hmm? 87. You don't know the answer? 86.
Yes, sir.
Yes. What is the
So
reason behind that?
excess ketone can be eliminated.
Okay. So that is why number one for the management of diabetic ketoacidosis, we use insulin, regular insulin. Okay, and we don't make the blood glucose directly to the normal. And this is same as that of hypertension in emergency, hypertensive emergency also. Okay, while lowering the blood pressure, we do not bring directly to the normal, isn't it? It was around 180 mmHg. It should be brought, and then slowly it has to be reduced. We read in second semester, isn't it? So similarly here also in diabetic ketoacidosis, you decrease, maybe 10% fall is well and good. Okay, and this blood sugar level will come around 300 milligram per dl in 2 to 4 hours time. Okay, so in 2 to 4 hours it will come here. We will try to maintain at 300 mg per dl. Okay, then of course I have already said when there is hyperglycemia, there will be osmotic diuresis, or dehydration will be there, isn't it? And okay, so electrolyte imbalance. So to cover up that, we have to use the intravenous fluid. So that is also an essential part of management of diabetic ketoacidosis. So here we use normal saline 1 liter per hour. The rate is slowly decreased till hemodynamic stability and adequate urine output are achieved. Okay, so when glucose reach 200 to 300 mg per dl, then 5% glucose in half normal saline is given. We will continue the regular insulin. Okay, but if we just go on continuing the insulin, then the blood glucose level may fall. So that is why we will add 5% glucose, so that it will be maintained at around 300 mg per dl. Okay, so 200 to 300 we try to maintain this. Okay, so this is also the important one. Then we will give, like once you start this regular insulin, slowly hemoglycemia, the hyperglycemia will be corrected slowly. The ketone level will be eliminated, and the patient will become to the normal. But one thing what you have to remember is, when you start insulin, the side effect of insulin is what? It causes what? Potassium level and insulin. What is the relation? Anyone?
Decrease potassium level, hypokalemic.
Yes, very good. So when you start insulin, giving this in very high dose, there is the potassium level may start falling. That is sure. So that is why you have to monitor the blood potassium level. So if there is hypopotassemia, the potassium level is less, then we give potassium chloride. Dose is determined by serum potassium measurement and ECG. Okay, so you have to consider this, and generally potassium is required. Okay, so that is there. And then sodium bicarbonate, it is given if, like, when you correct the hyperglycemia, when you correct the dehydration, this, that, the acidosis may also be corrected. Okay, but if it is not corrected, okay, then only if arterial blood pH is less than 7.1, okay, or acidosis is not corrected spontaneously. Generally, with all those measures which we have taken earlier, will correct this acidosis. If it doesn't correct, then you have to give sodium bicarbonate injection intravenously. Okay, and this is not very routinely needed. Okay, generally if the diabetic ketoacidosis is not very severe, okay, moderately severe case, the sodium bicarbonate may not be required. Okay, so but you have to measure the blood pH. If it is less than 7.1, then of course you have to give sodium bicarbonate. Okay, then last but not least, you have to find the precipitating cause. What is the cause for that diabetic ketoacidosis, and try to correct that cause. Okay, so that if the cause is infection, then use antibiotics. Okay, which antibiotic will you use? Roll number 85. Roll number 85. Absent? 84. Roll
Yes.
number 84.
Yes, sir.
Okay. How many types of antibiotic you know?
So, broad spectrum, narrow spectrum.
Okay. Any other way? You might be familiar with static and cidal, bacteriostatic,
Yes.
bacteriocidal, isn't it?
Yes.
Yes. Which one will you prefer in this case? Bacteriocidal or static?
Bactericidal.
Hmm?
Bactericidal.
Why?
So we want to eliminate them completely.
Mm-hmm.
To eliminate them.
Anyone? Eliminate. Okay. Anyone? Okay. Now, last is you have to eliminate the precipitating cause. What is the cause? Try to find if it is a stress. Try to eliminate the stress and do the thing. Stress doesn't mean that always it is a say mental stress. Okay, if someone is undergoing a surgery, that is also a stress to the body. Okay, even an infection is also a stress to the body. In that case, the corticosteroids will be released. So that those stress should be removed. And if it is an infection, that infection has caused the precipitation of diabetes ketoacidosis, then that infection has to be treated. And for the treatment, we will be preferring the antibiotic which is sensitive to that microorganism which is causing the infection. Okay, so microorganism, the sensitive, the antibiotic which can kill the microorganism, okay, or sensitive antibiotic is preferred. Out of those sensitive, it could be static or cidal. So you will go with cidal drug. Why? Because the immunity of the diabetic patient is less, the immunocompromised. These patients are immunocompromised, means the immunity power is less. So that is why static may not be a very good option. So you have to use a antibiotic which is sensitive and cidal. Okay, that is preferred. Okay, for the management of antibiotics. So this is all about the management of diabetic ketoacidosis. Do you have any question? Okay, now
Sir.
next one is hyper. Yes.
Sir, sir, do we have to use this medicine for whole life, or if there is
Which one?
treatment? Sir, these whole drugs of diabetes,
Which
do
whole?
you use for whole life?
Sorry.
Sir,
Which the antibiotics?
no, sir, for the drugs of type 1. Sir, there is saying in the society that this, if we take the medicine of diabetes, then we have to use this drug for whole life. Sir, is that true?
Generally, okay, it is in diabetic patient. Okay, like type 1 diabetes mellitus, you have to treat. Okay, and type 2 diabetes mellitus, like if someone controls the, you have to control the blood sugar level. If it is controlled with diet and exercise, well and good. If it is not, then you will be trying with the medicine. Okay, and if medicine is required to control, then you have to use the medicine for lifelong. But for this diabetic ketoacidosis, if there is infection and that has caused diabetic ketoacidosis, then in that case, till the infection is cured, we will be using that. After that, the drugs will be stopped. Okay.
Okay, sir.
This now next is hyperosmolar, or what we say non-ketotic hyperglycemic coma. Okay, so this is hyperosmolar state. Okay, there is hyperglycemia also and hyperosmolar, but there is no ketone bodies, and this is more common in elderly type 2 diabetes mellitus, which is characterized by severe hyperglycemia and severe osmolarity. So once you correct this hyperglycemia, automatically slowly the osmolarity will be corrected. But remember here, Due to osmolarity, severe osmolarity, maybe the electrolyte imbalance may occur. So that is why you have to check that. And there is severe dehydration and pre-renal uremia are common. So there is dehydration, okay, and there will be accumulation of the toxins, so pre-renal uremia may occur. So that is why the management, you have to think of that. It is similar to diabetic ketoacidosis, only the difference is the management of hyperosmolar coma is same as diabetic ketoacidosis, except what is the exceptional is you require more faster fluid replacement because there is more there is more dehydration. Okay, it is recommended dose of insulin is half of diabetic ketoacidosis because the patient is sensitive to insulin, and alkali is usually are not required. Okay, alkali means sodium bicarbonate. And then prophylactic heparin is recommended because the patient is more prone to thrombosis. Okay, so in diabetic ketoacidosis, we were not preferring heparin. That heparin was not needed, but in this case, it is recommended. Okay, so I think this is all about the diabetes mellitus, the pharmacotherapy of diabetes mellitus, etc. If you have any questions, you can ask. Otherwise, we will go with the MCQs. Do you have any questions?
Sir,
Yes.
so can we use statins prophylactically in the diabetic patient?
Now see, statins like diabetes mellitus, it is a metabolic disorder. If there is a chance of uh, 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 say the lipid label is distorted, you want to correct, then it could be used. And sometimes some cardiologist, okay, like the patient is having hypertension and other complications also along with the diabetes mellitus, they think that the uh, lipid label, if it is distorted, that may lead to more complications. So sometimes they will be preferring that is given. Okay, but it all will be discussed in clinical part. Okay, but for diabetes mellitus management, that is not required for your level for this basic science. Okay, clinical, when you discuss in clinical or MD, I have already said you that, isn't it? In diabetes, it is a very big chapter and very important also. So all those things, they are like use of statin in diabetes mellitus patient for prophylaxis. There is a big controversy. So I don't want to take you in that controversy. Okay, but sometimes some cardiologists say that okay, this lipid dysfunction may affect, so that is why statin should be taken. So that is all those things which will be discussed in clinical. So reserve this question over there because it is a controversial thing. I don't want to enter. Okay.
Okay, sir.
Okay, but for here, for treatment of diabetes mellitus, these are the therapy for pharmacotherapy. There is nothing else. If there is complication, then we have to think of other medicines. Otherwise, for treatment of diabetes mellitus, what we have discussed is more than sufficient. Okay, and it is as per your syllabus. Okay, so these are few lines which one has to follow to avoid all these chronic lifestyle diseases. Okay. Now, before ending, let us discuss a few MCQs. Okay, roll number 80. Roll number 80.
Yes, sir.
Yes. Can you answer question number 1? What will happen if insulin alone is given rapidly in diabetic ketoacidosis?
Sir, hypokalemia.
Yes, very good. Hypokalemia. Roll number 75.
Yes, sir.
Okay. Question number 2. What is the correct answer? A 15-year-old obese patient with type 1 diabetes mellitus is brought to emergency complaining of dizziness. Laboratory finding include severe hyperglycemia, blood pH of 7.1. To achieve rapid control of severe ketoacidosis, appropriate drug is what?
Sir, regular insulin.
Yes, very good. Roll number 70. Roll number 70. Are you there? Roll number 69.
Yes, sir.
Roll number 69. Yes. 69. Can you answer question number 3? Which of the following measure is not an essential component of the management of moderately severe diabetic ketoacidosis? Intravenous insulin, intravenous fluid, potassium chloride, sodium bicarbonate.
Sir, intravenous fluids.
No. 68. Intravenous fluid are essential, okay, and even to maintain the blood glucose to 300, you have to use 5% dextrose, and for dehydration and other, you have to use normal saline. So that is very essential. Without that, the management will not be
Sir,
completed.
potassium chloride.
Sorry?
Potassium chloride.
Potassium chloride, when you use insulin, then of course there will be hypokalemia, and that may lead to the cardiac complications. So that is also very essential. So which one is left? Yes? It is sodium bicarbonate. Okay, because when you take care of the hyperglycemia and the dehydration, and you decrease the ketone bodies, then automatically the acidosis will be corrected. So it may not be very essential. But if it is not corrected, then only you will go with sodium bicarbonate. So out of this, the less essential one is sodium bicarbonate. Okay.
Okay, sir.
68. 65 roll number. Roll number 65. Absent. Roll number 60.
Yes, sir. Hello.
Hello.
Yes, sir.
So,
Yes. Roll number 50.
Yes,
Which,
sir.
which insulin should not be mixed?
So insulin glargine.
Yeah, why?
So because insulin glargine is basic and others are acidic, and if we mix them, then it will neutralize.
Opposite. Opposite. Your answer is opposite. Insulin glargine is stable in acidic pH, so that is why it is made acidic, and that is the reason when we inject glargine, no, the in our body the pH is neutral, or say the other is basic, so that is why it is not mixed with the glargine, but other insulin are mixed. Okay. So this is all for today's class. Okay, if you have any doubt, you can. I will be posting the PPT slides, and in that side there is SAQ also. Okay, please try to solve yourself, and once you come here, you have to submit that. Okay. Okay. Can I stop the class?
Yes, sir.
Okay, thank you.